Hit the subscribe button or visit us at auau.auanet.org.
Thanks, Dave. And I'd really like to thank the AUA program organizers, as well as Dr. Gerard and Dr. Cookson, for the opportunity to be part of the faculty. It's been an honor to be part of this course and great fun to have the interaction. So we're also particularly looking forward to the case sessions. As mentioned, I'm going to cover the earliest part of advanced prostate cancer, which is biochemical recurrence. My financial disclosures are all in the area of non-muscle invasive bladder cancer, so are not going to be relevant for the topic today. And the way I'd like to organize this talk is to first discuss how we define biochemical recurrence and what we understand about its natural history, and then talk about the two most common therapies that we currently have for biochemical recurrence, which are what we call salvage radiation therapy and salvage androgen deprivation therapy. So I think it's very important to put us on the same page that we understand how the AUA defines biochemical recurrence after radical prostatectomy, and particularly for the residents and fellows on the line, knowing our guidelines is critical. And the AUA defines biochemical recurrence in this setting as a PSA greater than or equal to 0.2 with a second confirmatory PSA, again, greater than or equal to 0.2. Nevertheless, I think in clinical practice, we have to acknowledge that all patients with a detectable PSA following surgery are not at the same risk of subsequently developing disease progression and metastasis. And therefore, this is a call for a risk stratified definition of biochemical recurrence, and more importantly, a risk stratified approach to biochemical recurrence. So this was a very nice study done by Andrew Stevenson while he was at Cleveland Clinic, which looked at 14 different definitions of biochemical recurrence and correlated them with the patient's nomogram predicted 5-year probability of remaining progression-free. They generated curves like this, but more importantly than knowing the curves is understanding the concept that what they found was that if a patient had a 5-year nomogram predicted progression-free survival less than 50%, indicating a very high-risk patient, the best definition of biochemical recurrence for that patient was actually a single PSA greater than or equal to 0.05. On the other hand, if a patient had a nomogram predicted 5-year progression-free survival greater than 90%, indicating a low-risk disease patient, the best definition for biochemical recurrence in that setting was a PSA greater than or equal to 0.4 and rising. So the take-home point is that we may in clinical practice use a lower threshold of a PSA following surgery to define biochemical recurrence and, as we'll talk about, to institute salvage therapy. I'll spend one slide on biochemical recurrence after radiation therapy. What should we understand about it? We should understand how it's defined, which are known as the Phoenix criteria, which means the nadir PSA after radiation +2. We should understand how we should approach management, which is to first ask the question, would that patient be a candidate for salvage local therapy? If the answer is yes, proceed with further evaluation, prostate MRI, prostate biopsy to document local recurrence, and then metastatic survey evaluation. Now, understanding what we define as biochemical recurrence leads us to say, how do we understand the natural history after radical prostatectomy? And again, guidelines tell us that patients should be informed that the presence of a PSA recurrence is associated with a higher risk of subsequent developing distant metastatic disease and death from prostate cancer. What we understand about natural history in terms of biochemical recurrence is that it has been reported in approximately 1/3 of patients who undergo surgery. Now, it will be very interesting going forward as our paradigm has shifted towards operating on higher risk patients, whether that number changes in series to come in the future. But what's critically important to understand about the natural history of biochemical recurrence is that it is heterogeneous. And what I mean is that biochemical recurrence nearly always comes before systemic progression or death from prostate cancer, but biochemical recurrence by no means does universally translate into systemic progression or death from prostate cancer. Many more men will have a detectable PSA after radical prostatectomy than will ever develop clinical metastatic disease. In fact, as patients in this age group are often elderly and have competing risks of mortality, we have to be thinking about those factors. And one study demonstrated that patients with biochemical recurrence were as likely to die in the next 15 years from competing risks as they were from prostate cancer. In terms of thinking about that prolonged natural history in particular, what we have in terms of numbers to keep in mind come from data that were published out of Johns Hopkins over 20 years ago, but remain, I think, a very nice reference to have. And this is what's known as the POUND study. This is not a prospective clinical trial. It's an observational data set of 304 patients who experienced biochemical recurrence and were followed with no additional therapy. The mean follow-up of these patients was 5.3 years. And what they demonstrated was that about a third of patients with biochemical recurrence developed metastatic disease during this time frame. The median time from biochemical recurrence to the development of metastatic disease was 8 years. The median time from metastatic disease to death from prostate cancer was 5 years. So an overall time frame of 13 years from biochemical recurrence to death from prostate cancer. I think that's a nice number to sort of keep in mind and emphasizes with that sort of prolonged time course the importance of considering competing risks of mortality. We had a similar interest in this sort of understanding of the time frame at Mayo Clinic. We looked at our experience with a little over 2,400 patients who had biochemical recurrence after surgery, and again, were treated with no adjuvant therapy. Our median follow-up was a little over 11 years after surgery. And what we found, very similarly, cancer-specific survival at 15 years after biochemical recurrence was 84%. In our series, about a quarter of patients received salvage therapy at the time of biochemical recurrence and before systemic progression, which has raised the question, can instituting salvage therapy impact the natural history of biochemical recurrence to clinical metastatic disease? This is a follow-up study that came out of Johns Hopkins, now in 635 patients. Again, not a prospective trial, but an observational cohort study. Of these men, 238 received salvage radiation therapy. Their follow-up now was 6 years after BCR and 9 years after surgery. And what they demonstrated was that patients who received salvage radiotherapy for biochemical recurrence did have significantly improved cancer-specific and overall survival. So given the retrospective nature, has to be viewed as hypothesis generating, but nevertheless introducing the concept that we may be able to interrupt the natural history of biochemical recurrence with salvage therapies. Now, again, just as we talked about different risk stratified definitions of biochemical recurrence itself, we have to be able to risk stratify and think about patients who experience biochemical recurrence. This was a nice multi-institutional collaborative study of a little over 2,200 patients with biochemical recurrence, no adjuvant therapy, just about 4 years of follow-up, that developed a nomogram to predict prostate cancer death among patients with biochemical recurrence. And you can see the parameters that are included in this nomogram: age at diagnosis, speaking to competing risks, a series of PSA kinetic parameters, as well as pathologic parameters from the initial surgical specimen. So again, I introduced this as a statistical model tool for you to be aware of for use in clinical practice. Nevertheless, I think it's even more user-friendly for everyday clinical practice to think about what the EAU published just a few years ago in terms of risk groups. Rather than a nomogram approach, they produced high-risk and low-risk patients with biochemical recurrence based on two criteria: PSA doubling time, greater than or less than a year, and pathologic Gleason score at surgery, greater than or less than 8. And what you can see here are the criteria for both low-risk biochemical recurrence and high-risk biochemical recurrence. These criteria have already been validated in a surgical cohort of over 1,000 patients with biochemical recurrence with long-term follow-up, demonstrating, as you can see from the curves here, how these risk groups nicely stratify patients' risk of subsequent cancer-specific survival. So again, something to be considering in clinic tomorrow in terms of how we risk stratify patients who experience biochemical recurrence. So now that we understand that, let's move towards how we manage biochemical recurrence, and we'll start with salvage radiation therapy. I've termed this in parentheses early salvage radiotherapy because, as our guidelines tell us, the efficacy of radiotherapy for PSA recurrence is greatest when given at lower levels of PSA. What does this mean? Here are data from our Mayo Clinic radiation oncology cohort, a little over 1,100 men with biochemical recurrence treated with salvage radiotherapy, follow-up 9 years. What they found was that the overall biochemical recurrence-free survival after salvage radiotherapy was 50%. That's a nice number to keep in mind because it has been reproducibly reported from multiple series. But what they also demonstrated was a key prognostic factor for salvage radiotherapy being the pre-salvage radiotherapy PSA cut point. And what you can see from these cumulative incidence curves is that patients who were treated with salvage radiotherapy for a PSA less than or equal to 0.5 had significantly better subsequent biochemical recurrence rates, distant metastatic disease rates, and improved cancer-specific mortality compared to patients treated with salvage radiation therapy for a PSA greater than 0.5. Nice multi-center experience, again led by Andrew Stevenson. Here, just about 2,500 patients who received salvage radiotherapy, median follow-up 5 years. very similar to the Mayo data, the overall 5-year biochemical recurrence-free survival was about 50%, but they very nicely illustrated the importance of the pre-salvage radiotherapy PSA cut point. So as you can see, patients treated with salvage radiation therapy with a PSA less than 0.2 had a 5-year biochemical recurrence-free survival of 71%. 0.2 to 0.5, that dropped to 63%, 0.5 to 1, and beyond that, you can see clearly the correlation of subsequent disease control with the PSA at the time patients received salvage radiotherapy. What about using androgen deprivation therapy together with salvage radiation? We're aware of the data of improved survival among men getting primary radiotherapy for high-risk disease of adding ADT. Here in the salvage setting, we have 2 prospective randomized clinical trials to be aware of. This is a French trial that randomized patients who were being treated with salvage radiation to 6 months of androgen deprivation therapy. Primary endpoint, progression-free survival. Large 700-plus patient trial with 5 years of follow-up. And what the trial demonstrated was that adding 6 months of ADT to salvage radiation significantly improved progression-free survival with a hazard ratio of 0.5. The investigators subsequently updated their experience with 112 months of follow-up. And again, the results from the primary analysis were maintained. Adding short course of ADT to salvage radiation significantly improved progression-free survival. A second prospective randomized trial that's gotten a lot of attention that was published in the New England Journal of Medicine from the RTOG group led by Bill Shipley, randomized patients getting salvage radiation therapy to 2 years of high-dose oral bicalutamide. Primary endpoint in this trial was overall survival, and the median follow-up was 13 years. Again, 700-plus patients. And what these investigators found was that adding androgen deprivation therapy to salvage radiation therapy significantly improved overall survival, significantly decreased the risk of death from prostate cancer. So based on this sort of level 1 evidence, the AUA Astro guidelines were updated in 2019 to state that clinicians should be offering hormone therapy to patients treated with salvage radiotherapy. Now, I will say that these salvage therapy guidelines are currently under re-review by the AUA. In the interim, the question remains, should all patients who are treated with salvage radiation therapy need androgen deprivation? They should all be offered it by our guidelines. How can we select patients to receive ADT? Well, we participated in a multi-center experience with a European consortium of about 525 patients treated with salvage radiation therapy. About a third got androgen deprivation therapy. And what we found was that adding ADT was really only of benefit for the highest risk patients, those with PT3B, P4 disease, those with grade group greater than or equal to 4. What about using the pre-salvage radiotherapy cut point? I talked about early salvage radiation therapy. This is a secondary analysis that was done on that Shipley RTOG 9601 trial that I discussed just a few minutes ago. They looked at the prognostic value of the pre-salvage radiotherapy cut point of 0.6. And what they found was that patients who got their salvage radiation therapy with a PSA greater than or 0.6 had a significant overall survival benefit from concurrent ADT. On the other hand, for patients that were being treated with what we would call early salvage radiotherapy, PSA less than 0.6, androgen deprivation therapy did not improve overall survival, but actually was associated with worse other cause mortality and increased cardiac and neurotoxicity. You can see these curves here. Among the early salvage radiotherapy cohort, no benefit with ADT to overall survival, worse other cause mortality. How about genomic classifier? There's been increasing work using the Decipher genomic classifier specifically in this disease space. And again, another secondary analysis of that same RTOG clinical trial had Decipher testing available on about half of the patients from the study. And what they found was that in that early salvage radiotherapy cohort, which in this manuscript they defined as PSA less than 0.7, patients with a low genomic classifier had a limited benefit from preventing distant metastatic disease with androgen deprivation therapy and a worse overall survival. Some elegant figures from that manuscript demonstrated, as you can see here, early salvage radiotherapy cohort, low genomic classifier score Decipher, very limited benefit for distant metastatic disease with ADT, but in fact, worse overall survival with androgen deprivation therapy. Speaking to how in the future, we might be able to individualize ADT with salvage radiation. Another topic that's been investigated with prospective clinical trials has been the question of adjuvant versus salvage radiation therapy for patients with high-risk pathology at radical prostatectomy. We have 3 prospective trials and 1 meta-analysis. The largest of those trials is known as the Radicals clinical trial, almost 1,400 men with these adverse pathologic criteria at radical prostatectomy. They were randomized to either receive adjuvant radiation therapy after surgery or an initial course of PSA surveillance with salvage radiotherapy at an early state if they experienced biochemical relapse. And what the investigators found in this trial was nearly identical biochemical recurrence-free survival at 5 years between patients treated with adjuvant or early salvage radiotherapy. And in fact, adjuvant patients had worse urinary continence at a year and increased urethral stricture disease at 2 years. A second trial from Australia and New Zealand, known as the RAVES trial, 333 men, again, adverse pathologic criteria at surgery, very similar randomization, 6 years of follow-up, again, nearly identical 5-year biochemical recurrence-free survival, worse GU toxicity in the adjuvant treated cohort. These two trials were combined into the artistic meta-analysis that was published in Lancet in 2020, a little over 2,100 men. Bottom line from the meta-analysis was no evidence that event-free survival is better with adjuvant radiation compared to PSA surveillance and early salvage. That's led to an update in our AUA guidelines, which now state that adjuvant radiation should not be routinely offered to patients after radical prostatectomy. The question remains, is adjuvant radiation therapy dead completely? And that calls attention to looking very carefully at clinical trial eligibility criteria. This was a very nice commentary by Anthony D'Amico and Daria Tilke, which pointed out that although these are 3 prospective randomized trials and represent level 1 evidence, in fact, the trials included a relatively few number of patients that we would consider to be at the highest risk for biochemical recurrence. Only 5% had positive lymph nodes, and a minority had either Gleason 8 to 10 or seminal vesicle invasion. And therefore, they conducted this retrospective evaluation that they published in the Journal of Clinical Oncology, looking at adjuvant or early salvage radiation therapy in node-positive or high-grade extraprostatic disease patients. They looked at the primary endpoint of all-cause mortality and had a little over 8 years of follow-up. This is the schema from the, again, retrospective trial design. And what they demonstrated that patients who had this type of adverse pathology, node-positive, extraprostatic high-grade disease, did have lower all-cause mortality when they received adjuvant radiation. Patients without adverse pathology had no change in their all-cause mortality with adjuvant radiation. They put this elegant figure where I've highlighted in different colors the 3 prospective clinical trial criteria, showing that patients who met those trial criteria did not have a benefit from all-cause mortality with adjuvant radiation. But in the top box, patients who met either node-positive disease or extraprostatic disease with high grade had lower all-cause mortality. So again, retrospective design needs to be perceived as hypothesis generating only. How about genomic classifiers in this disease space? Again, the Decipher test has been looked at in a variety of different retrospective analysis. This is one study of a little over 500 men who a combined Decipher score with clinical features to develop an individualized risk tool for adjuvant radiation. They found that patients with a low risk score, there was no benefit to adjuvant radiation in terms of preventing clinical recurrence. In terms of patients with a higher risk score, those who got adjuvant radiation did seem to have a lower rate of subsequent clinical recurrence. Again, however, when we look at our guidelines, the panel concludes that the level of evidence, which at the time was retrospective, cannot discern whether genomic classifiers can be used as standalone to predict the efficacy of adjuvant versus early salvage radiotherapy. So I'll finish by spending a few minutes on salvage androgen deprivation therapy alone for biochemical recurrence. Here we have several retrospective series and one prospective trial. This was a study published a little over 15 years ago, but remains an important reference because it was really the first large study to look at this. 1,300 plus patients with biochemical recurrence, published by Judd Mal and colleagues. A little over a quarter got androgen deprivation therapy at the time of biochemical recurrence and before clinical bone metastatic disease. Follow-up was just about 5 years. And what the study demonstrated was that in the overall cohort of patients with biochemical recurrence, there was no benefit to early androgen deprivation therapy in terms of delaying the development of bone metastatic disease. However, when they looked at specific, what they called high-risk cohorts of patients, Gleason 8 to 10, PSA doubling time less than 12 months, early ADT did delay the development of clinical metastatic disease. And what's very interesting to flash forward here is that this is back in 2004, Gleason 8 to 10, PSA doubling time less than 12 months, same criteria that in 2019, the EAU used to define their high-risk, low-risk biochemical recurrence risk groups. These are two more recent cohort studies one in a little over 2,000 patients, no difference in all-cause or prostate cancer mortality with immediate versus delayed ADT for biochemical recurrence. The second study in nearly 6,000 patients after either radiation or surgery, whole cohort, no benefit of ADT in the salvage setting for all-cause or prostate cancer mortality. But again, those with the most rapid PSA doubling time did have decreased all-cause and prostate cancer mortality with salvage ADT. One prospective randomized trial I think it's important to be aware of out of Australia and New Zealand, known as the TOAD trial, 293 patients with biochemical recurrence randomized to immediate or delayed after 2 years ADT, followed for 5 years. Now, there are some statistical considerations with the trial because it was closed early to accrual. Nevertheless, they reported 5-year overall survival significantly better in the immediate versus delayed ADT cohorts, as you can see here. Nevertheless, I think as we talked about at the beginning of this, whenever we're thinking about treatment, we have to come back to what is our understanding about the natural history of the disease. This was a study published last year by Johns Hopkins documenting the natural history of 800 plus patients with biochemical recurrence and no androgen deprivation therapy until they developed metastatic disease. Median follow-up 9 years. What they showed that the median metastatic free survival was 16 years, median overall survival 17 years, and this kind of prolonged survival even existed among patients with what we would call a rapid PSA doubling time. So we have to understand the quite prolonged natural history, and therefore it's not surprising that when we look at our AUASUO guidelines that were updated in 2020, patients with biochemical recurrence after local treatment should be offered observational clinical trial enrollment and not routinely initiated on androgen deprivation therapy. Caveat being that when ADT is initiated, intermittent ADT may be utilized. Now, to finish, I think it's very important to set up our next talk that we have to understand that the whole entity of biochemical recurrence is evolving as our imaging advances. Again, restaging evaluations are recommended in patients with biochemical recurrence. And now that we have more and more sophisticated and improving next generation imaging, such as PSMA PET scans, what historically was biochemical recurrence may in the future with more sophisticated imaging actually be early oligometastatic disease. So what do I want to leave you with here in conclusion about biochemical recurrence? First, know the AUA definition, greater than or equal to 0.2 with a confirmatory value. But when you're treating clinically, consider it in the context of disease risk as well. Remember that the natural history of biochemical recurrence is heterogeneous and can be quite prolonged. So consider competing risks when you're considering treatment. High risk by the EAU, Gleason 8 to 10, PSA doubling time less than a year. Salvage radiotherapy, if you're going to do it earlier is better, less than 0.5. Offer, at least at this time, ADT, especially in high-risk disease. We have trials comparing adjuvant versus salvage radiotherapy with no significant difference. So our guidelines do not routinely recommend adjuvant, and most would favor PSA surveillance with early salvage therapy. The role of the genomic classifier continues to be defined. What about salvage ADT? There's conflicting retrospective data. We have that TOAD trial that's positive in small numbers. If you utilize it, consider intermittent ADT in that setting. So with that, again, I want to stop and thank you very much for the opportunity to speak this afternoon.